see everyone again. So just a quick thing if you don't know who we are. So I'm Dr. Peter Blakey, former president of the Vet Association. I used to also have a company called RX Vet, and then did a few other things for a while, and then started GLA Pharma. So we're a small family-owned business. GLA stands for Grace, Lucinda, and Alexandra. So my three daughters. So definitely a very, very small team and a very small family business. So there's three of us full-time and one of us part-time, Dr. Penny Moran here in Wellington, who does our regulatory work with myself, Kim Miller up in Auckland, who's the key account manager, and Danielle, she's our marketing manager, also based in Auckland. So yeah, just wanting to, we've got the privilege of having Helen here tonight. Many of you will probably know of her. She does a satellite clinic here in Wellington every one Tuesday a month. So Helen graduated from University of Queensland in 2001. Has worked in a variety of countries, Australia, New Zealand, US, UK, and did a small animal boards for the Australian New Zealand College in 2007, and then started doing dermatology and worked for the Animal Dermatology Centre and got her diploma in 2021. So yeah, very, very lucky to have Helen here tonight. She's going to talk to you about the identification and management of secondary skin infections. So, Helen?
Thanks for having me. I'm just bringing mine up. I'm here with Danielle, who's one of my fabulous Dannies that I have two nurses, both called Danny, which is very convenient for me. So we've just had a busy day in Kilburn today, which has been fun. So apologies if I'm a little tired looking. So Peter, if I just press that little icon at the bottom, is that right? I don't know, hopefully it's quite a small screen and you're quite a wee way back. So if you're having trouble seeing, please come forward. I feel like we're doing myself a little bit of a round table discussion. I'm going to try sitting and see how that goes, because I'll just be able to move the computer a little bit. I'll probably get up and move around, so but yes, I thought tonight we could talk about skin infections. Hopefully a lot of this you will already know, but you might pick up on some new things, and certainly open to discussion. So please feel free to ask any questions. I think most of you, I'm not sure there's a few familiar faces and some people I don't know, but we are, I was based at Massey for several years when I was doing my residency, and prior to that working in community practice at Massey. And we are just about to we have moved into our new clinic just over the road from Massey, and we are having our first birthday on the 1st of May, which everyone's invited to. You may not feel like coming up to Palmy on a weeknight, but if you do, you're very welcome. We're going to have some derm fun and games. But this is our little team. So Danny L is to my left on this side. She's here tonight. This is my other Danny on the other side. So that's my team. We work very closely together in the clinic in Palmy, and then Kirsty, those of you who've rung and emailed probably have communicated with her. She works in Auckland and is organised those sessions. Moving along very well. So we're going to talk about skin infections, and as far as skin skin infections go, the most common one is a bacterial pyodermas, and there are three classes of pyoderma which we'll go through because they are important as far as how we approach them and the differentials we should be thinking about, and they're classified based on how deep they are through the epidermis and the dermis. The most common bacteria that we isolate, at least in dogs and in a lot of cats too, is Staph pseudontermedia. So I'll be predominantly talking about Staph pseud tonight. Malassezia dermatitis is also really common, as you well know. We won't go into a lot of detail about that tonight, but happy to take questions about it. And I think it's just important to remember that almost all skin and ear infections, and ears are a whole nother lecture, so we'll do that some other time, but they are secondary. So it's very rare for us to have primary skin infections. So we really need to be thinking about why the skin infection has occurred. We're going to go over the diagnostic approach and then review some treatment and management. Some important reasons, I guess some of the reasons it's important, some of the implications for us as pets, but also as people on this planet. Pyoderma and Malassezia dermatitis are really important flare factors for atopic dermatitis, which clearly I'm seeing several times a day, and I'm sure you are as well. So we see skin infections, nearly every case. Most skin infections are treatable, and I say that in inverted commas because of some of the micro dysbiosis that we'll talk about a little bit later, because they're not really treating these infections. We are managing them, and we are trying to normalise the skin microbiome, but they do relapse unless the underlying disease is addressed and controlled or managed to the best of our ability. This microbial dysbiosis is not a new thing, but it's certainly becoming a really emerging thing that we should be thinking about. So I'm going to talk about skin infections, and I'll have it on the slides, but in my mind, hopefully I can convince you as well that we really should be thinking about this as being a microbial dysbiosis more than infection in many cases. There's certainly a massive impact on the quality of life of the patient, but also on the owner. So there's a big burden on owners of these animals that have to pay for the treatment and do all of the things that we ask them to do. Antibiotic resistance is an increasingly important concern. So a really large problem overseas. Luckily, not a massive problem here yet, but I think it feels like it's only a matter of time before that does become more of an issue. So let's try and get in early and see what we can do to try and slow that down. There's certainly zoonotic potential with MRSP, but also MRSA between humans and animals. We should be, not just thinking in our bubble of in our clinic, but also thinking about the One Health implications and approach for what we're doing, and that the drugs that we're giving these animals that then can get into into the human side as well. Always trying to be responsible in our use of antimicrobials. And I'm not going to talk a heap about antimicrobial stewardship. I do think it's a really important area. We're very lucky to have Lucy here tonight from the NPI, who will be, helping to educate us all as we go with that too. And this lofty goal, which I think you had a part of, Pete, that by 2030, which is only 6 years away, that New Zealand will be, at least on the veterinary side, antibiotic-free was what they were the standard. So, how we're all feeling about that. I think we're actually a long way off achieving that. We are helped by having, companies like GLA Pharma who are bringing in, the derm care topicals, which is fabulous. Without good topicals, which we haven't had a lot of, and until recently we've started to get a little bit more trickling through. But if we don't have the topicals to treat these problems, then how are we meant to talk without antibiotics? So very grateful to you guys for bringing that in. I know how hard it's been to do that. So just to go over the classification of canine pyoderma, we talk about surface pyoderma. So they really encompass what we would call hotspots, but also skin fold pyoderma or intertrigo. Superficial pyoderma is mainly represented by superficial bacterial folliculitis, which we see very, very commonly in our dogs with atopic dermatitis, but also impetigo in puppies, and mucocutaneous pyoderma not infrequently as well, and then deep pyoderma. And we talk about FNF, which is folliculitis and furunculosis, which can be localized or generalized, and can be more superficial or deep. So why that important because it really does help to guide the diagnostic steps and the treatments that you should be thinking about for these types of pyoderma. It helps us to decide how and where to sample the lesions that might be useful diagnostically. It helps us to understand where we should be sampling these for culture, and should we be sampling these for culture? You know, it's all those decisions that come into it. And you know, when we're considering treatment, are we trying to manage these topically, which by and large we should be trying to, or do we need to employ a systemic antimicrobial as well? So pyotraumatic dermatitis, which is the fancy name for a hotspot, you will see these regularly. I know they're usually self-inflicted and they are acute and often really, really painful. They usually result from some underlying cause of pruritus. So whether that's a flea allergy dermatitis, whether that's an atopic dog, whether the dog's got otitis or a foreign body, or we often don't. We may not know initially what the cause was, but we certainly see relapsing hotspots in atopic dogs very commonly. What's happening in a surface pyoderma or with the hotspot is, at least in the early stages when we classify them as a surface pyoderma, it's just disruption of the surface of the stratum corneum, but they can progress to a deep pyoderma. So they can, the follicles can become involved, they get inflamed, they infected as well, and then they rupture and then you've got furunculosis. And then you probably all click these up, and then you've seen where they've got some satellite lesions around. So you've got the main one, and then you've got some others, and that's actually a sign of a deeper infection because now we've got hematogenous spread, and so they're popping up in other areas. Diagnosis of a hotspot, usually fairly typical clinical appearance. They shouldn't feel thickened, so when you feel them and it's you've got that ulcerated, eroded surface, but there's no sort of depth to it, that's still a hotspot. But once it has more of a plaque feel and is quite a lot thicker, that's a sign that things are going deeper. And it's kind of important. It is important to recognise that, because if we have a purely surface, early hotspot that we recognise, that should respond really well to topical therapy. If it's starting to, if it's a deeper infection, then that is one you may need to reach for some antibiotics. The cytology on these is, you'll hear me like a broken record going on about cytology, because we really need to be doing it in all of these cases, and you will usually find a mixed bacterial population, and they're often opportunists. So there's not any kind of one that's more likely than another really good surface pyoderma, and we really have to be thinking about what the underlying cause is if they're relapsing. So one-off, not too worried we can deal with that, but if there's something that they're coming back, obviously we need to be looking at why that's happening. So skin fold intertrigo, we see this all the time with all the Frenchies and bulldogs and the brachycephalic breeds that we see. So certainly a predisposing factor is having a face full of folds, but we do see them around the lip, for the lip fold on the lower lip for dogs, vulval folds as well, tail folds again with these bulldog breeds. But also with BCD too, so they can have a fold that's between the mammary glands. They can have more folds, the ventral neck. So anywhere where there's deeper folds, there's an opportunity there for surface pyoderma to occur. Friction is often a big part of it, and that's particularly true in the in head skin areas like the face folds and the tail folds. Causes a lot of disruption of the surface of the skin. Obviously those areas have got increased humidity and warmth as well, and so all of that helps with the bacterial overgrowth. Interdigital is a massive, a massive type of this surface pyoderma that we see in atopic dermatitis. These also are affected with microbial overgrowth, and staphylococcal species, and usually Staphylococcus aureus is the most common thing that is found, but often there's seizure and there can be other commensals as well. So you do need to do cytology to identify that, so that you can choose the right treatment. Sometimes these are not very inflammatory, and that's sort of the textbook definition, I would say. But in my experience, and I think a lot of people do find this too, there's often a lot of inflammatory cells there too. Clinical signs are fairly obvious. It's erythematous. There's often an exudate. They often can be, quite pruritic with this, and you can sort of peel back these folds and they can be eroded and ulcerated in there. So really quite a mess. Always do cytology, as I said on this. You're going to need that to choose your, the appropriate topical. It's also worth always, thinking about checking for genetics with these dogs as well. Sometimes this is how they present, and always thinking about what could be the underlying exacerbating factor. Is it just that you're a Frenchie with, lots and lots of folds, or is it also that you're a Frenchie with atopic dermatitis? Or do you have, is there a dermatitis, and that's why we've got these problems. So always thinking about that. The treatment for surface pyoderma should always be topical, and that choice, as I said, it should be based on cytology. I think in addressing the inflammation with these is really, really important, and we'll usually use a topical steroid for this. You might be able to use a combined folic, so something like an isoderm, that has an antibiotic and a steroid as well. So that could be useful. Some of the wipes and things like that are really helpful as well. So the chlorhexidine, which is impregnated wipes. You could use are you going to talk about your product tonight? Okay. So there's DermCare are bringing in, which has been out in Australia for a little while, hasn't it? A leave-on chlorhexidine conditioner, but we can use it like a lotion, right? That's how it sort of feels, and that's really nice. Use of something like that would be a good thing to get in some of these folds. But you want to keep them dry, you want to keep them clean, and you want to reduce inflammation. So that's your goal with these. And really, systemic antimicrobials shouldn't be required. So this is where it's important to recognise that something surface pyoderma and be really focusing on the topical therapy with these. I think not forgetting about the anatomical issues and that surgical correction, if it's a possibility, so it's something like a vulvoplasty, or you can remove a face fold, that kind of thing. It's really worth considering. I get a lot of questions and from vets about recurrent infections of vulval folds, that kind of thing, and what antibiotic should I use, what should we be doing? When it's happened kind of 3 or 4 times, actually, just throwing more antibiotics, this is not really the answer. Actually, fixing the problem and removing the fold with a surgical correction could be really could be the best thing for that dog. Think about atopic dermatitis. Get sick of me hearing that, saying that word, and as I said, check the genetics. You're not going to find it often, but when you do, it's a game changer. Impetigo is usually a young dog problem, so this is what we call puppy pyoderma. What you see clinically, if you look really closely, is that these are non-follicular pustules. So if you get down and have a little look closely, you'll see pustules, sometimes papules, but they won't be they'll be between hairs. So if you get close and have a look, you won't see a hair coming out of the middle, which is different to a folliculitis. Most common in the inguinal area and the axilla, so in that glabrous non-haired skin, but there can be other areas as well. They're usually mildly pruritic. And just to remember that, or maybe remind you that impetigo is rare in adult dogs. So if you are seeing that, then that should raise some red flags for something else maybe going on. One of the potential underlying disease with that is Cushing's or hypercortisolism. So just another, there's a lot of these diseases that can mimic other things and they can look like infections. So unless you go looking for the underlying cause, you might be going down the wrong track with these dogs. Diagnosis, history, how they present, clinical signs, pathology again, and again these should be treated topically. So chlorhexidine shampoo is a good option for these dogs. A leave-on chlorhexidine products will also be great. Something that you can cover a large area with. Superficial bacterial folliculitis is what we deal with, and you will deal with, every time you see an atopic dog, probably. Clinical lesions, these are follicular pustules, so it can be hard to find that, but if you have a ferret around and find some some pustules, and some papules. Often you'll see there's a hair coming out of the middle of it. Sometimes they've fallen out, so it can be hard to find them sometimes. But these are orientated around hair follicles. As the lesions age, we'll really commonly see epidermal collarettes. And we get questions from vets and trying to educate students about this too, that these are circular, sort of spreading kind of lesions, and they often have a hyperpigmented centre. I think I might have a picture of one shortly. And people always want to call this rootworm, but it's very, very, very rarely rootworm, especially in our in New Zealand, in dogs. This is most often epidermal collarettes, and they're actually also called staph collarettes. So these are a very, very common lesion with staph folliculitis. The hairs, the follicles are often lost, so these dogs often end up with alopecia, and it can be particularly marked in short-haired dogs, so they get this really, and that's what the picture is of this really moth-eaten appearance. So you get these kind of pock-mark-looking areas where it's often quite circular, with that clump of hairs has fallen out because it's been affected with folliculitis. These are usually paretic, but not always, and often these dogs are also on Apoquel or Cytopoint or prednisone. So those drugs could be masking the pruritus in these dogs with folliculitis, and the opposite is true too. So sometimes, well, not even sometimes, quite often, having a bacterial folliculitis can be the reason why the Apoquel stops working. Not really, but it's still trying to do its thing. But you've actually got a bacterial folliculitis, and that's why the dog is still itchy. So keeping that in mind as well. Diagnosis, history is going to be fairly obvious. These dogs will often have atopic symptoms as well. Cytology again is really, really critical because yes, these are usually staph, but they might not be, or they might also have analysis dermatitis, and so it is really important to be looking and checking. Think about some of these other differentials for other causes of folliculitis in dogs. So Demodex is a possibility here again, and we're going to look at skin scrapes. We're going to take hair plugs and do trichograms to look for those. Demodex is not something we do treatment trials for, so they're easy to find. We just need to look for them, and we can find them relatively easily. Dermatophytosis can look like does cause a folliculitis and can mimic a bacterial folliculitis. So diagnostics is going to be warming up and pulling out the wood lamp. Doing cytology, we can see the after spores of Microsporum on cytology sometimes. Trichograms again, looking culture and histopathogen or methods for definitive diagnosis. And think about some of the sterile pustular diseases as well. So thinking about pemphigus here, this lady, but that is, and they can often have secondary infection too. But it's not uncommon for pemphigus to look like a folliculitis. You'll have pustules. It'll be often in all the right places as well. So there, you need to go look at cytology. If it doesn't not quite fitting all together, you're not seeing bacteria there, then biopsy is not going to be the way to go. Treatment of bacterial folliculitis. Because the pathogen in 90% of cases is Staph pseudointermedius, we can make some empirical choices to talk about that. But topical therapy is usually sufficient. So obviously there's factors that come into play with the size of the dog and how much of the dog is affected. They have the ability for the owner to be able to use the topical therapy effectively. But there are, a couple of studies out now, and this is just one example from a few years ago now, where they compared dogs that were treated, that had superficial bacterial folliculitis. Some of them were treated, that's the standard way, with a 4-week course of amoxiclav given twice a day. And then 2 other groups of dogs were treated either with twice weekly 4% 4-hexadene shampoo bathing, or daily application of a 4-hexadene spray for the same length of time, and they all resolved in the same time. So it is possible to do it, and Danny will laugh at me because I always we were very fortunate to have a dermatologist from Edinburgh talk to the group, our interest group last year, Tim Nuttall, and he was fantastic. And I've got lots of little he's just in my head talking about this thing, but he made a really good point. He said, do we want to be the ones that have to explain to our children that the reason that we have such problems with multi-drug resistant bacteria, or there's nothing that we can use to treat their skin infections because we couldn't wash our dogs, and so I think it's it is a big problem. We are overusing systemic antimicrobials for these sorts of things where we don't need to. So be thinking about the big picture with these, and topicals, they do need to be done right, and they do need to have the right contact time and all of that, but it is possible to do it. When are we going to reach for systemic treatment? Because we do have to sometimes, because we know that by and large we've confirmed on cytology that we can see cocci, we're most likely going to be Staphylococcus medius. We can, in most cases, choose to make an empirical choice, and we would call this like a first tier, or a green light, depending on what kind of system you're looking at. New Zealand's going for a sort of the traffic lights, the green and yellow and red. But the antibiotics that we should sort of think about as first tier generally, and this varies a little bit from country to country, but is amoxicillin, clavulanic acid, cefalexin, clindamycin, and trimethyl sulfur. Or we're making our choice based on culture and sensitivity. I'll talk more about when that's appropriate in a second. Make sure that the doses we're using are correct. If we're reaching for an antibiotic, we need to have weighed the animal. Have a current weight. Don't be going off what they weighed 6 months ago. Make sure we're using the right doses. So we need to be dosing antibiotics at the higher end of the dose range for skin infections because the blood supply is poor. So we need higher doses to achieve the minimum inhibitory concentrations that we're aiming for to kill to kill these bacteria. Treat them for the right length of time. So the current length of time that's recommended for a bacterial folliculitis is 3 weeks. There will be changes. So things are going to be, probably changing quite a bit in the next few years. But the current recommendation is 3 weeks. And if you're not going to treat the animal for 3 weeks, then you need to make sure that you are getting them back in 10 days or 2 weeks or whatever you've decided on to check that they actually are cytologically clear now, so that you have actually treated them from the right length of time. It's really important that we do a recheck before they have finished the course of antibiotics, so that we can repeat cytology if there's still lesions there and know if there's still bacteria present or not. Do we need to extend the course? Is it being given correctly? Has the dog been spitting out the tablet? They're just been using it once a day. All of the different things that can happen, but rechecking is really, really important. And I can't emphasize enough how important communication and support for owners is in achieving good compliance. I'm lucky enough to have a team that that's all they do. That's not all they do. They do lots more than that. But a big part of what we do is checking in with clients and making sure that they are managing. Can they give the tablets? If they're vomiting and they stopped, or all the different things that can go on. And I know that we're busy and that we don't have enough support staff and all of that goes on, but I think that this is something that we really should make a priority. Another form of superficial pyoderma that we see is mucocutaneous pyoderma. My mentor hated this term actually, and I think it's he's like he didn't really believe in it, but it was, and I think it's because it can, it's quite, maybe it's an autoimmune disease, maybe it's a lupus, maybe there's other things going on and we've just got secondary infection. So he's probably right, but it is an area that can become affected with the superficial pyoderma. The lips are a common site, and they can have a lip fold pyoderma as well, which is just that little crease that dogs have on their lower lip. But with a mucocutaneous pyoderma, it's actually the whole length of the lip affected. So a bit like the picture of that dog in the photo there. Erosions and ulcerations are common. It can be other mucocutaneous junctions as well. diagnosis is going to be, how they look clinically, cytology again, check what you've got going on. These ones are difficult to differentiate from immune-mediated diseases such as lupus for the pathologists. So, and sometimes clinically it's hard to tell as well. We might have some depigmentation, certainly erosions, alterations we'll see with some of the autoimmune diseases. So what is a really useful thing to do if you've identified infection there is to treat that, and whether that's topically plus or minus systemically. They often do need systemic in this location around the mouth because they just lick all the topicals off, so it's quite hard to get something to stay around long enough to do the job. And then if it hasn't resolved completely, so you've done your 3 weeks of your antibiotic, you've tried to do some topical as well as best you can, and it hasn't resolved completely, that's the time to biopsy. Because discoid lupus and erythematosus, or DLE, and mucocutaneous pyoderma look identical to pathologist on histopath. So if you can biopsy them, and in your your notes, the pathologist, which I know we're all writing really well, that you can say, and this dog has just finished a course of antibiotics and now we're biopsying. So that helps them in their mind to get off the fence and say, okay, well, if you've done that, hasn't resolved, it's more likely to be DLE. So that's just one example for that. As I said, systemic is often usually it's very localized. So what's going through my mind, and what I hope you guys are thinking about with your decision making when prescribing an antibiotic for superficial pyoderma. So I've said that an empirical choice without conscious sensitivity is okay a lot of the time, and it is. But some of the provisos on this, I guess, are that the dog shouldn't have had just be coming off a course of antibiotics. I really shouldn't have had antibiotics in the, in the close future. And I've said 3 months, and that's not set in stone, but that's kind of what I'm thinking. If the dog hasn't had a course of antibiotics in the last 3 months, and we're seeing it now with a pyoderma, then I'm not super worried about it. Resistance necessarily in the first instance. You have to have seen cockeye on cytology, and there needs to be no prior history of that dog having an MRSA infection. So on the other hand, I do think we should be doing culture and sensitivity if antibiotics have been given recently, and let's say, in that last 3 months, if there has been a prior history of MRSP, if we're seeing, and maybe it's mixed, but if we're seeing rod-shaped bacteria on cytology, so it's not just cockeye, and if you're seeing this dog back at the recheck and it has been treated appropriately and that you've checked compliance, everything seems okay, still got lesions and you're still seeing cockeye on cytology, that should be a red flag for you, and that should be an invitation to submit a sample for culture. And if you've got any reason to suspect that dog might have, be compromised in some way, and that might be related to concurrent illness, it might be drugs that the dog's on, Eddie again. There's reasons why we might decide that would be a good idea to culture. That one, just make sure. This is what I'm sure you're all very familiar. This is what I see all the time. Are you guys familiar with? I'm sure you're. So we don't. This is a smear from a from a folliculitis, a pustule. These are neutrophils, and all of this streaky purple stuff. It's purple spaghetti, as I call the students. I call that chromatin. So we don't. These are neutrophils, but they're not nicely preserved like they are on a blood smear. We've smeared them across, and they're really degenerate, and they've kind of spewed themselves everywhere. So this is all of the proteinaceous chromatin material from neutrophils, and we've got lots of cockeye in the background. It's probably a little hard to see from your distance, but staff love to do little 2s and 4s and sometimes more, so they do little clusters together. So that's very typical of how a staph bacteria looks on cytology. So deep pyoderma, this is starting to get into, these are harder to treat. The big issue, a lot of the issue with these is this folliculitis and fronticulosis, as I mentioned. So that's occurring, and it ends up with follicles that have ruptured deep down in the dermis, which sets off a massive inflammatory response in that deep part of the skin. As a result of the furunculosis, when the follicles are all rupturing, now we have free hair shaft or keratin that's floating around in the dermis, and the body is not designed, we're not meant to see that hair, so it's usually immunologically protected inside the follicle. Once that's ruptured and now it's floating around, it acts almost like a grass seed in the dermis. So there's a massive inflammatory response to that. So that's where we get the pyogranulomatous reaction. So masses of neutrophils, but now we've got macrophages, we've got eosinophils, we've got other monocytes, everything coming in along with the secondary infection. So that's that's why it's not enough just to treat the the surface of what's going on in these deep pyodermas. Localized deep pyoderma we commonly see over pressure points, so elbows, hocks, that kind of thing, but also on the face, on the cheeks, over the digits. We'll quite often see it in the chin and muzzle, especially in the giant breeds with their short, bristly hairs, and we really commonly see interdigital folliculitis and folliculosis as well. They can have, I'm not going to go into it too much, but they can, we do see generalized deep pyoderma. These dogs are usually more systemically unwell, so they're, there's bigger things to be looking at with that, and they can also develop cellulitis as well. So this is an example of a callus pyoderma. This is a dog that we saw probably just about 6 weeks ago now. He's had these before, but this is a recurrence that he had these big, massive, swollen, almost not callus, and they were callus, but they were huge and swollen over both of his stifles, his elbows, and further down on his hock as well. And as I say, I do think we see these more commonly in the large breed dogs, particularly when they have that short, spiky hair. And this is just anecdotally, but it was something that I learned through my residency from the dermatologist that trained me, is that Rottweilers do seem predisposed. We don't really know why, but they love to do calluses and they love to do deep pyoderma really, really well. They often have draining tracts, so they are often oozing out, serous sanguinous, thick fluid. There's often, I'd say nearly always, an underlying problem, and whether that's atopy, whether that's the dog may have a bed provided but actually chooses to lie out on the concrete. Sometimes hypothyroidism, so it's worth keeping that in mind, that sometimes these dogs are not dealing with their secondary infections very well because they're hypothyroid, so it's worth checking. But diagnosis, again, clinically how they look, always cytology on these, and we do need to do cultures on these, and I'll talk about that a bit more. The acrylic dermatitis is another form of deep pyoderma, which unfortunately becoming one of my most hated things to deal with actually, is quite common. It's caused by just continual pruritus flicking, often at the cranial aspect of the distal foreleg. It can be, this dog's actually got them on both of his forelegs. We can fit in other places, but it's usually a distal limb. They're defined by a raised, thickened plaque. There's often central ulceration, erosion, and these usually have this whole F and F thing going on too, so folliculitis and bronchiolitis. There's always an underlying problem. Atopy, again, it's a common one. And on top of that, or maybe on its own, maybe they're also an obsessive compulsive dog too. Maybe it's an arthritic joint. There's all sorts of things that can trigger this, but once they're added, and once you've got a deep pyoderma, then it's just this ongoing tinnitus of infection and pruritus. Cytology, yes, it's helpful, but what we do know is that the surface cytology, and this is an old paper now, but they looked at 22 dogs with acrylic granulomas, and they compared what was grown on the surface to what was grown from a deep tissue culture, and it only matched in 8 of the 22 dogs. So, it's you get some surface cytology, but we shouldn't be basing our treatment on what we get on the surface. We really need to know what's happening down deeper. And we do need to be, as always, all of these things are different underlying causes. My second least favourite thing to deal with is this interdigital furunculosis. Do you guys see this a lot? Do you see these dogs? I think we see this a lot in lots of breeds, but particularly again the bulldogs, the big heavy mastiffs. These dogs that have, got all their weight in the front, big flat feet. We see this. This is actually quite a nice snuggling foot compared to some of the ones that we see. Conformation is a big issue with this. So yes, they're often atopic. Yes, there's there's some anatomical problem, but a big part of the problem is that if you lift up the foot and have a look on the the plantar or the palmar surface, is they've slipped off walking on their pads. So rather than being up on their nice thick leathery skin of their pads, they're now actually weight bearing on the haired skin that's adjacent to the pads, and so then it ends up being those hairs are pushed deep into the skin that triggers folliculitis, triggers folliculosis, and now we've got this beast of inflammation that's going on in the dermis, which is just looking for its way out. And so they often track up between the toes, on the side of the pads, and blow up out on the top. So it looks like the problem's on the top or between the toes until you flip over the foot and you see, okay, this is where it's all originating from. So they're very difficult to deal with. You do want to make sure that they don't have Demodex. So sometimes these do. So it's worth looking for that. Again, hypothyroidism sometimes is an underlying factor to consider. But diagnosis, again, they're pretty classic with their appearance. Cytology, yes, it's useful, but again, these are deep pyodermas, so culture of deep tissue is the best way to go. Histopathology sometimes, particularly if you're trying to rule out something like Demodex, and it's a difficult place to get a good scraping in between the toes like that, and ruling out other differentials. Treatment of deep pyoderma, as you'd all be very aware, this disease can be really severe and very painful. Treatment is required for extended periods, so we're usually looking at using antimicrobials for at least 4 weeks, and sometimes much longer than that. So it's it's a big commitment from owners to do this. And yes, staph pseudomonas is often a cause, but at least in the reference I was looking at, and this may not be that might vary a little bit, but it's not the cause as often as it is in a superficial pyoderma. So in around 60% of cases, you might expect to identify staph, but that leaves 40% that is something else. So if you've made an empirical choice based on what you're maybe seeing on some surface cytology, or based on what you think could be going on, you could be wrong, a lot of the time. So when you're thinking about, starting this dog on a month-long course of antibiotics, you might be completely the wrong one, but it's also expensive for the owner if you get down the track and you've actually, it hasn't improved because we're not addressing the right bacteria. So I think because empirical choice is more difficult to predict, then it's really recommended that we do culture for these. Deep tissue culture for aerobic, anaerobic, and fungal is the ideal situation. If you can't do that for usually financial reasons, I guess, or maybe it's false economy, I would argue, then taking a swab from a deep draining tract is a second best option. Don't just throw what's coming, what you find on the surface. These are really severe, they're painful, so I usually do start an antibiotic based on what I'm seeing on a deep swab from a draining tract while I wait for the culture and sensitivity result, and then we'll shift tack once we get that back. Some other therapies to think about. We do have a phobia lamp from Benacrenal. Does any of you guys have this in your practice? You got one? Yeah. So I find this really helpful for deep pyoderma. So I think it's we just need more things that we can use apart from antibiotics for these diseases. So this is a pretty novel fluorescent-like therapy that is showing some pretty promising results with lots of different inflammatory, infectious problems in the skin. So it's a good thing to have. And again, always looking at why this is happening. Hopefully, most of you know how to do this, but I did. I'm going to drop Kate Gillinder, so she's not a dermatologist, so I don't mind. But she had to take a tissue sample from her dog, and she's up in somewhere off the Wasps, New Gisborne somewhere. And so I needed to talk her through taking a sample for deep tissue culture from her beautiful visitor. So I just thought, just in case any of you weren't sure exactly what to do either, then it's a good thing to have a chat about. The main thing is that we want to get deep tissue for culture, and we want to try and avoid surface contaminants. So usually in dermatology, we're all about not clipping, not cleaning the surface. We just want it all raw and dirty, and we want to know what's going on. But when we are taking a sample for deep tissue culture, we actually do want a surgical prep. So you're allowed to clip, and I want you to prep it, but then try and, and rinse off with sterile saline that's good at the end. When we're taking the biopsy, that can be with a nice big, say maybe 8 or 6 millimeter punch biopsy is fine, or you could take a wedge with a scalpel, but you want to make sure you get deep enough so that you're reaching down into the subcutaneous fat paniculus layer, and then lie the sample on its side when you get it out, and actually use the scalpel to cut off the epidermis, and you can just throw that out, and then keep what's left, so your dermis and any fat tissue there, and that's what goes into the culture. So we're trying to avoid growing the staph or whatever we've got going on the surface, because they will overrun the plate, and it might mean that we don't see the actual grow, or it's hard to recognize what's growing in the deep tissue. We use e-swabs a lot for this. Are you guys familiar with the e-swabs you can get from the lab? They've been a game changer for us. They're really simple. We use Rebels, or whatever they call themselves now, and I think they're $5 or something like that. They're not expensive, really, the swabs, but it's a swab that's in a liquid medium, and they're literally just called an e-swab. So you can use the swab if you're going into a fistulous tract or whatever you're doing, but for something like this, I would actually not use the swab, but we would put the tissue in that liquid medium inside the tube. And they're fabulous for aerobic, anaerobic, and fungal cultures. So really, that's been really helpful to have those. But if you don't have those, that's okay. You would wrap the sample in a sterile gauze swab that's soaked in sterile saline, and then put that whole thing inside a little yellow top bottle or something like that, and send that into the lab for culture. What are some things that we should be thinking about that do impact antimicrobial therapy? Obviously, antimicrobial resistance, the severity and the extent of the lesions that I've been trying to explain to you. If you've got surface, if you've got a little bit deeper superficial, now we've got follicles involved, and now we've got a deep folliculitis, bronchiolitis. That's going to influence what we're doing with our antimicrobial therapy. Obviously, we need to be thinking about patient factors for for our cats and dogs. Is it a golden retriever with an 85-year-old owner? Is she going to really struggle to be able to wash that dog appropriately? Do we need to clip the animal? All these factors that come in. Temperament, the environment that they live in, what might be happening concurrently, that might impact how well this animal is going to respond to antimicrobial therapy. As I said earlier, owner compliance is essential. We are sending these dogs home with their medications, and we're relying on owners to be able to do that. And sometimes they can't, so we need to make sure we provide good instructions, we give support, make sure they're able to complete the treatments that we've sent home. And support the communication is critical for that. What are the advantages of topical therapy? Well, there's many. We certainly see potentially more rapid resolution of lesions, which is what we're aiming for. If we're using them alongside systemic antimicrobials, then we'll see a decrease in the length of time that we need to use systemics for. So that's a very positive thing. But as well as that, we're actively, especially with shampooing, actually removing debris and microbes from the skin surface as well. So that can be really helpful when we're now shifting to prevention of secondary infections or overgrowth. There's minimal adverse effects to topical therapy. Of course, they can, dogs will want to lick it off, and cats are need to use topicals from often, but generally pretty mild adverse effects. And a big thing is that we're not now exposing bystander organisms that didn't need to be caught up in all of this by using a broad spectrum antibiotic in this dog. So that helps to reduce the risk of inadvertent emergence of resistant strains. Resistance to the high concentrations that we achieve with topical therapy with antiseptics and with antimicrobial drugs topically is really uncommon. So there is you know, I don't think we're checking for it yet, are we? But I don't think there's not been documented yet that we have any resistance problems to chlorhexidine. It has been documented overseas, but it's not common. So luckily, we don't see very many resistance problems because we achieve such high concentrations, because we can have, you know, duration of action there. And topical antimicrobial agents, luckily, are really typically, you know, very effective for resistant staph. So just to been able to talk, I'm happy to talk in more detail about this if you want to, but I guess, you know, in a sort of simple terms of diagnostic approach to the dog in front of me that's critic, and, you know, I can clearly see from the lesions that it has a pyoderma, we're going to be, you know, really thorough history taking, because yes, 9 out of 10 dogs that I see, you know, with a folliculitis are ectopic, but what if it's not? You know, what if this is a dog with dermatitis, or a dog with hypercorticism, or a dog with hypothyroidism, or, you know, maybe this is a dog that's actually got a capillary trophic lymphoma, you know, all the other things. So we're going to be taking a thorough history, looking for systemic signs, thinking, you know, delving in and looking really closely and working out if it's follicular, it's non-follicular, on the surface, on the superficial, on the deep, you know, a combination, what's going on, because that's going to help you to put together a differential list for what might be the underlying cause of this, which then helps to come up with a plan. Then clearly there's tests we need to do. It's always going to be cytology, so that's always going to be the correct answer, but it may also include skin scrapes, it might also include biopsies, it might also include taking some samples for culture and sensitivity. Hopefully by then, you know, you get a diagnosis, you start to see improvement, but it's always coming back and reviewing your approach if we're not seeing the expected resolution. Treatment of infection, you know, we're really emphasising that we can do a lot of good topically, and we should always be using topical, and then we might be adding in systemic as well. Cytology, you know, it really, I know that it's another step to take when you're busy in the clinic, but it really is pretty quick to do. It's easy once you get confident at it, or just get practice at it, and it's really pretty cheap. So I don't think there's any excuses to not do it. You know, I think it's that important that we should be, you know, always aiming to do it, because really, you know, how can we choose an antimicrobial, whether that's topical or systemic, if we don't know what we're seeing if we're seeing on cytology. And I'd go as far as to say that we really can't prescribe an antimicrobial therapy, especially a systemic one, if you haven't done it. You know, we really are guessing. We can't smell bacteria, we can't smell yeast. You know, we can get some idea of what's going on if you're seeing epidermal collarettes. We're very likely to suspect there's going to be staph, but you don't know for sure unless you check, and there might be something else growing alongside it. So it might also have a rod, you know, pseudomonas growing on it or something like that. And also, importantly, we need cytology to be able to monitor progress and response. You know, how are we going to know if we have a resistant problem if we haven't rechecked cytology? We don't know what's happening. Some tips that we were thinking of as a group to help increase the use of cytology, because I know you guys are probably all amazing at it, but, you know, we see lots and lots of records for you know, dogs and cats coming in where cytology hasn't been done. And I'm like, what are the barriers, and why don't we do it more? One thing that if you have the, you know, the staff, and I don't think there's any point training up everyone to be able to do cytology, but if you could find that nurse or support staff that is interested, at least even a little bit, then, you know, training them up and giving them, you know, a role in helping you with staining slides, and, you know, even so to look at them, it makes a world of difference to me that my team are able to, you know, collect samples, stain them, be looking at them, reporting back, and I'll go and I'll review and have a look as well. But I think it improves your job satisfaction mostly, I think, anyway. And it's, you know, it's a really, really helpful, and they're a lot more patient than I am too often. So see if you can get someone in the clinic to help with that and charge for it. So we used to struggle a bit, you know, even, you know, people coming to see a specialist would often, you know, bulk at the price of things and be like, well, you know, our vet's just did cytology last week, so I don't really think we needed it previously. So we've just changed the way that we offer it, and now it's just part of your consult fee. So it's just built in. So it's not an option to not do it. If we, on the rare chance that we don't do it, then I do discount it and I take it off. But otherwise, it's just a set price, and that's your dermatology consult, including any kind of initial diagnostics that we do. So that might be cytology, it might be skin scrapes, trichograms, stuff that we can do in-house. We're going to charge extra for the cultures and livestock and that kind of thing. But I think that's helped a lot. We have less pushback on the diagnostics that we have to do for these cases. And something that I did while I was at Massey, after listening to someone talk about it, and it kind of carried on, and now we do, is just to make up a dermatology box that literally I just carry around with me under my arm when I was at Massey from the furniture room. Now I just have a little lunchbox thing that we walk around with, and that's got everything you need in it. So it's easy access. You can get topped up, every day, and just make sure you've got everything you need in there. But that's really helpful. You're not like, oh, I can't find the slides, so it's too hard. I haven't got time to go find them in the treatment room. Not going to worry about it. If it's right there with you, then it's an easy thing to do. This is what we have in ours. So we use slides with frosted ends and right on the location. We have blades in there and do skin scrapes and the paraffin for the same purpose. We have some clippers, we have some scissors, we have a pair of hemostats in there to put some hairs for trichograms. Do you guys like using tape for collecting samples for cytology? You do that? So just making sure you have the right tape so that it's clear and really sticky. So I really like Scotch tape for that. Just having a roll in there, have your swabs, have the toothpicks. I know some of you probably heard me talk about that before, but we just have a little bottle of cocktail toothpicks in there. And that's a really fabulous technique for getting up in the nail fold. So just taking a little bit of that goop around the nails. You'll find malassezia, you'll find bacteria, you'll find all sorts of stuff in there. Really, really helpful. We have the culture swabs in there, the e-swabs already. We have, actually it usually doesn't stay in there, but I like having a ruler in there because I'm always like, oh, was it 2 centimetres, was it 3 centimetres? I just, if I'm recording things, so I know, be able to mark on your slides. A sterile toothbrush, which is what we use for dermatified culture. So you can just have that in there as well. A lighter for heat fixing if you need it. An otoscope, have a lot of combs so that you can have a new one for every ear and you can clean them really well between patients. Everyone's got a phone in their pocket. Dermatology is really visual, which I love, and it's really, really helpful to take photos of your patients. So what do we do for follow-up? As I said earlier, I think you need to recheck them, and it needs to be while they're still on treatment so that you know whether it's, whether if they've relapsed, has it been, has it just never resolved, or has it, is it going to, is it going to relapse? Repeat cytology if lesions are present. The general guideline is that there should be at least 50% reduction to be considered improvement, and we often see more than that, in 3 weeks' time. As I mentioned, if you're still seeing bacteria on cytology, then that should be a red flag to you that you should be looking, at least thinking about whether you have a resistant problem, as long as compliance has been up to scratch with everything else. Reassess clinical signs, because we know by and large that these infections are secondary. So if we haven't looked for why they're happening in the first place, at some point they're going to relapse. No, is it going to be back? And we've already been through this treatment. Why are we having to do it again? So be proactive about looking for a primary cause. We will see these and we can come back as you all have experienced. What are some challenges? So a couple of things broadly, but recurrence / relapsing pyodermas. So these are cases where there has been complete cytological and lesional resolution of the pyoderma with appropriate treatment, and then they relapse. So whether that's 2 weeks later, 4 weeks later, 8 weeks later, but they've relapsed. This is really, really common, as I said, when the underlying problem's not addressed, but also antimicrobial resistance. So this is lack of resolution and continued progression often, despite appropriate treatment. how do we manage these recurrent relapsing pyodermas that we see all the time? Probably harped on this enough. Look for the underlying cause. Review them regularly. If there's things that you know could potentially lead to flare factors that you can control, like fleas, make sure you know that you're covering all that, and so that we don't have fleas as a potential flea factor. Really, pulse therapy of antibiotics has been discouraged for quite some time, and we shouldn't be doing that. We still do pulse therapy for malassezia with itraconazole, but that's because it is a different drug. And it does become incorporated into the stratum cornea, so it does hang around for longer. So we kind of get away with it with that, but I think even that we will still that will still be frowned upon as well. We do. I think it's really important that we think about preventative maintenance regimes or therapy with topicals, and often that includes antimicrobials and steroids, depending on what we're treating. These are often inflammatory as well. So rather than going back onto systemic antimicrobial therapy, let's think about doing preventative topical therapy, and that might look, just as an example, bathing once a week, using one of the leave-on topical antimicrobials once a week, depending on that maybe that we can alternate week to week, but we'll see how it is per case. And then, for example, for an atopic dog that has recurrent pruritus of the paws and ears, we'll use a topical steroid for them once to twice a week. So it's just an example, but we do a lot of preventative maintenance plans for our patients. Atopic dermatitis is just one slide on this, but just often the underlying cause for pyoderma, but also malassezia dermatitis, often both going on simultaneously. We have to think about reducing the inflammation of the skin in these guys, as well as the pruritus. So we're going to try using topical glucocorticoids for the inflammation of skin, ears, and other parts of the skin as well. And then symptomatic relief of pruritus with our Apoquel cytopoint drugs most commonly, and then cyclosporin too. Move out Apoquel and cytopoint, and then melanosis too, but they don't work as well for the inflammation of ears and paws. So we're often combining them with a topical steroid, and that combination with Apoquel cytopoint plus a topical steroid really works well. This is where allergen-specific immunotherapy comes in for the long-term management of these guys, thinking about could this be a food allergy trigger, and looking to that, and then always doing what we can to support skin barrier functions. That bathing, diet, there's more and more we can do for that moisturizer. Just to touch on what I mentioned at the beginning is the kind of the way we should really be starting to think about, even though we say infection, and that's the easy way to explain it to owners, what we are starting to understand is that really is a microbial dysbiosis in canine, and probably atopic dermatitis as well. And what that means is that there's a reduced richness of the microbes on the skin of atopic dogs. So they have reduced microbial diversity. When a dog's treated with antibiotics, it restores the microbiome to something more approaching normal, but you never eliminate the staph. So it's not really correct to think about it as treating the staph, because you're not getting rid of them, you're just bringing them back into more normal levels. So it's really a dysbiosis rather than infection in most of these cases. And once they come off the antibiotics and things start to slip back into their atopic way, especially if we're not doing some of this preventative maintenance with topical antimicrobials, then that diversity is lost within 4 to 6 weeks. So it doesn't last very long. So it's a kind of a futile attempt when we're trying to treat this infection all the time, but actually it's just going to return to its normal dysbiotic state fairly quickly. And the same situation occurs in canine otitis externa as well. So this is, some of you will have seen this before, this is just one study. So this is a normal, beautifully diverse microbiome in normal dogs that are not atopic. The next 3 are atopic dogs, so let's visit one before we've done anything, and the pink in this scale is the staph. So it's massively out of proportion, and there's, I don't know, you probably can't see from the back of the room, but much less diversity. All the little coloured lines here are all different type of microbes, and it's much reduced in an atopic dog. This is, the dog's now treated with antibiotics, and I think it's 2 weeks later. So we've now got something approaching, still not normal, but there's less staph and slightly more coloured lines with all the other microbes. And then at the third visit at 4 weeks, we're not completely normal, but we're much approaching normal compared to how we were in the first visit. But that will you'll lose all that diversity again within about 4 to 6 weeks. So how do we manage that? It is the atopic flares that and the skin barrier dysfunction that really drive this dysbiosis. So it's really important to focus on changing the skin environment to prevent the dysbiosis rather than treating it as secondary infection all the time. Probably a line that I also got from Tim Nuttall is that think about, that dogs with recurrent infections don't have antibiotic deficiencies. They've got a microbial dysbiosis. That's their problem. So trying to avoid referring to skin infection because it implies to owners that this is something that can be treated and cured when in fact that's not the case when you're atopic. And it certainly does promote the use of antibiotics as well. Clinical challenge is clearly antimicrobial resistance. We're mainly talking about methicillin-resistant staph pseudo, but also methicillin-resistant Staph aureus as well. Oxacillin, we always call it MRSP and methicillin, but in New Zealand, oxacillin is used as what's the right term for that? As the marker, I guess, for methicillin resistance. And this means that they're resistant. If you're resistant to oxacillin, it means you're resistant to all of the beta lactams. Okay, so and they're getting better, the labs now. Initially we were getting some through and it would say oxacillin resistance, sensitive to amoxiclav, cephalexin, cephaloxime. So ring the lab and oh yeah, that's right. So I think they're getting better now at reporting okay, even though we need to report that as resistant. They can be multi-drug resistant, and I've got an example to show you in a minute. So never treat them empirically when you've got when you've got a resistant infection. But the good thing is that resistant staph, they're no more virulent than the normally normal staph, normally treatable staph, and they do respond well to therapy. So it's not. Yes, it's a bit scary when we have one, and owners get potentially get a bit freaked out. But it's up to us to reassure them that they're no more virulent. They're easy enough to treat. We just have to take some steps to make sure we're using the right thing. As I said, it is a major concern worldwide, and MPI are working on collating some data to know really what the situation is in New Zealand, but it's increasing. That doesn't seem to be a major issue here, but I think it's only a matter of time, and we really do have a responsibility to responsible antimicrobial stewardship. So this is just one example. This is Murphy. So we first saw him in May 23. He came to me and he's atopic, of course, and he was absolutely covered in infection. So you can see on the culture we grew a heavy grief. This is a Gribbles report, and they don't speciate it out to Staph pseudo-intermedius. But that's what they mean. But anyway, hopefully that will change. But there's a heavy growth of Staph pseudo-intermedius. Let's call that Staph pseudo-intermedius, even though they call it Staph intermedius. Heavy growth of Proteus, moderate growth of Strep, and a light growth of E. coli. So he's got it all going on. Hopefully the little highlights work. So it was resistant to trimethoprim sulfur, so this has come the wrong way around. Anyway, so resistant to oxacillin, this is the main thing that was going to come up there, sorry, which also means resistant to amoxiclav, cephalexin, and cephalexin, and also as an added bonus, resistant to trimethoprim sulfur. So in Murphy's case, and also resistant to penicillin, so I think that's gone the wrong way. Sorry. We'll try and put these on the graph. The green one, we actually treated him, the green one with penicillin. So in this case, we did choose a fluoroquinolone because it was really the only option I had that was going to treat all of those. So we did choose, and I don't do that lightly, but I did choose enrofloxacin for Murphy. And then we saw him again a few times, and then we saw him again in September and actually repeated the culture, because now we had treated him and he'd been all right, but then we checked him on cytology and we still were finding cocci on cytology. I'm like, we've got another problem. We probably should do another culture because we're just not, we don't seem to be winning with you. So now he's oxacillin sensitive, but we're still now we're resistant to tetracycline. We were sensitive to that before, and doxycycline included with that, and still resistant to trimethoprim sulfate. So they can change. This is one dog within a few months, and with I don't know how much you believe this, Lucy, but now he's now he's not hasn't got it. Yeah. No. Yeah. But it was kind of like, well, I needed to do it again because now we have a different choice to make. And so for this time I chose clindamycin. So I could have used enrofloxacin again, but I didn't want to. I'm trying not to use it. So this time clindamycin was a good choice for him. So certainly anecdotally, I would say amongst dermatologists, the prevalence of MRSP appears to be increasing. I don't know if that's any of your experience of what you're seeing in your clinics, but I was really happy to talk to Lucy, who's here tonight, who is part of the antimicrobial resistance team at NPI, and you are presenting some of the surveillance data that you've been collecting over the past 18 months, 2 years or so, at the NZBA conference in a couple of months. So that will be exciting to see what comes out of that, and really, really pleased that we've got a team of people that are looking at it and really glad their jobs didn't get cut with this latest yeah. It was really important. But we've certainly got it here. It was first diagnosed in a dog with chronic dermatitis, probably atopy, in 2014. This is a map from the paper in 2023 when they looked at I should have given this that reason. I think that's the wrong date, sorry. But anyway, looking at clinically normal dogs in Canterbury, 73% of them carried status U, but none were identified as MRSP. The number of clinics, just from our a quick little tool through our data, is that we probably see one MRSP case every 2 months. So that's more than I'd say we were seeing 5 years ago, but it's not horrendous. But we are actively looking for it. So I wonder how much we're missing. There might be maybe we have got a higher incidence of winning than we realise. Interpretation of sensitivities that we get back at the moment, the labs are all using the distribution technique, so we get sensitive and intermediate or resistant, and that's all we get. That will be changing, so they're rolling out the MIC, which is the minimum inhibitory concentration method, in the dairy sector soon, I think, and so that will be coming for us in companion animal at some point, hopefully in the not too far distant future. That's a lot harder. It is harder. It's more complicated to read, and we'll need some training about that so that we can learn how to interpret that. It's much more dynamic. It is more reflective of what's going on in our local population. So I think it's a really good thing. It should be the way we go, but and hopefully not too far off. I think avoid using, even if it comes back as intermediate, I would just avoid using the intermediate sensitivities. And I just learned that ciprofloxacin is not available anymore. Is anyone using it? I think this was used as a marker. Yeah, a lot of people a lot of vets are using it. Yeah, and it is included on a lot of our sensitivity panels. Yeah. No, it does come up, and so it's and whether it's just we don't people understanding that why it's on there, but seeing coming up as sensitive, but it is a very unreliable drug to use in dogs. So the bioavailability, the absorption of that drug is very random. Sometimes it's fine, sometimes it's really, really not okay. So we really discourage people from using it. And even if it comes up as is resistant to enrofloxacin but sensitive to ciprofloxacin, the cipro is a metabolite of enrofloxacin. So they are, it's pretty sure it's on here. Yeah, and it might be, but we don't know that. So, oh, good, it's sensitive to scissor. I'm going to use that, and it's so cheap here. And it has been used quite a lot. It is available. I've been a bit scared of using it because it's like we have one case where I had one dog ages ago developed KCS, and so I'm scared of it. But having been reading and doing all this, I'm like, I should probably go back to it. But it just has higher risk of side effects. Yeah. But I think, is anyone using it readily? Is it readily available? I should be. Yeah, I know, but maybe we should. Try to. Yeah. So it's cheap and it's good for, it's a good thing for big dogs. I know, and we should. Yeah, I know, but we just need to go into it. Get them in, do the Chantilly test, and it's aplastic can happen, so it's kind of a little bit of a scary job, but I think if we're monitoring, and it's it's a first tree drug, and it is one that we should be looking for. So
that's fine. I know that my doctor used when I had things like some other effect.
Yeah,
the doctors are using it way more than we do.
Yeah.
So it's still one otherwise in the they just throw this stuff out.
Yeah. Because it's not Pavlov's.
Yeah.
Yeah.
Using vapors.
Yeah, exactly. So good enough for us. We should. So what can we do? Nearly finished. I guess we're in a very fortunate position in New Zealand that we don't have a lot of it. We don't have a lot of MRSP. So we have an opportunity to be different from everywhere else. And actually, I don't think we're going to prevent it completely, but we can take steps to limit it. So every time you reach for a systemic antimicrobial, think about what you're doing and what the potential consequences of that might be. That you are effectively influencing the whole microbiome, and is that really what it's really not what we need to be doing in most cases. So what can we do instead? We can identify and treat the underlying cause. We can use anti-inflammatory treatments. If we're, and that's actually, I think it's just come out in the Vet Journal this month or last, is that actually for canine otitis, when they've got malassezia or Popeye on cytology, just treating those dogs with a topical steroid is enough. So we don't even need to use a topical antibiotic or antifungal for a lot of these cases of otitis. And I would say the same is often true for skin. If we can settle the inflammation, settle the pruritus, we may not even need antimicrobials for these cases. Yes. Yeah. So we use it's only a couple of veterinary products, so we use human products a lot. But yes, they are. Yeah. Oh yeah. And I'm not going to go into any detail because you have some standards in your clinics, but thinking about your clinic, what's happening with hand washing, where you're going, wiping down tables, treat every pyoderma as if it could be an MRSP. And then we're going to limit the spread in our hospitals, and also think about our own hygiene and educate owners about what they need to be careful. Not ridiculous, but just being careful and washing hands. Just being sensible with your hygiene. So top tips for pyoderma management. The prognosis is good for most infections, even if it is MRSP. The vast majority of the time they're going to do fine. I think I've harped on the identification managing primary cause enough. Harped on about cytology enough. But we should be doing more culture-based prescribing. In this day and age, as we're seeing more resistance. Practice good antimicrobial stewardship. Promote that in your clinic. Get everybody on board with that. Use topical therapy all the time, and certainly more often than we have been, and provide support for owners, and then we should see improved compliance with that. Just one slide on when it looks like infection, but it isn't. So this is why cytology is so important, why history is so important. Doing thorough clinical exams. These dogs, one cat, pemphigus, terrible pemphigus. I think that was pemphigus. stuff. So these are all kind of examples of different pemphigus cases, which could look, you know, if you clinically look at that, you're like, oh, it's a cardiac, no, it's a cardioma. But go looking, check cytology, take biopsies, and these are actually not cardiamas. So thank you for listening. Thanks for coming out on a weeknight. Happy to take any questions. There's my brief email and my personal email, so you're welcome to send any into me as well. I think that was all I had.
Any questions for them? Thank you very much, Helen. That was fascinating. That you know, still the most simplest thing we can do is psychology. To yeah.
Easy, and you don't have to. I'm not trying to name or shame anyone, but like, is cytology something that you're actively able to do in the clinic? Is it easy enough to do? Yeah, that's really good.
All right. Now, I was going to quickly talk about some new products that are coming, but we're still waiting for the ACM to process those. So I will just mention them, as Helen has talked about. So we've got a 5x dedicated conditioner, 4x leave-in conditioner that is coming very, very soon, hopefully. Certainly progressing with the manufacturing of it, so that'll be hopefully at conference time. We've also got a leave-in steroid, budesonide-based steroid coming in that wood. We're hoping to have that last year, but that'll be September, October for the skin season. So yeah, that'll be
it's always skin season.
Yeah, true. Yeah, particularly spring. So yeah, and I just wanted to quickly come into them. Anyway, oh, yeah, that's it. Oh,
yeah, it's yours.
So just, I know it's getting late, so I'll just quickly just got to tell you that little things. So I'll just do it. It's easier. So we've got a full range, and everyone please grab a goodie bag if you haven't already. We've got our range brochure in there which details all the products we've got. Plus we've got some samples of our new toothpaste and one of our new pheromone products. So the ones we've launched lately, we've got Cilio. I don't know if anybody's an oral mucosal gel, dexmedetomidine, great for noise anxiety, but also a lot of people using it for pre-clinic visits. 20-30 minutes before the owner can give it. Works at about 23 bucks for a 20 kilo dog. So that's cool. So we've got some new pheromones, new whole new range. We've got sprays, collars, spot-ons, and we have diffusers coming at the end of the year. What else? We also have the new Flexi Plus range. So the dental display box down the back there. It's a clinically proven range. So it's got the VOHC, Veterinary Oral Health Council approval. So which means that we have to go through a whole bunch of rigorous tests to prove that it actually does work. You've got to have a greater than 15% reduction in either plaque/tartar or plaque or tartar calculus, and with the water additive. So just a couple of capsules into the water for the pet showed a 21% reduction in tartar or calculus, and that doesn't seem like a lot, but when you compare it to toothbrushing, which is the gold standard, toothbrushing only actually achieves about 37% reduction. So yeah, and that was with the water additive. So as you know, it's not going to contact the teeth for very long. So if you're using the toothpaste, the spray, or the wipes, it will you would expect it to get an even better response. So so we do have a promotion on that. And so in your little goodie bags, there's an order form. So if you order one of each of the four spray, the wipes, and the toothpaste, you can get the full point of sale display thing to stick up on the counter. As a part of that Pluckley range, is also another couple of products. We've got the Orostrip DX, which is a cool quick 10-second test that you can yourself or a pet nurse receptionist can, when the dog's just waiting in the waiting room or the cat, put it in it's best on the maxillary, space between the gums and the lips. 10 seconds, pull it out, and it's got a qualitative colour change. So That's graded depending on the severity. It measures the thiol concentrations in the saliva, and it's correlated very, very well to periodontal disease. So it's actually the gold standard is, of course, anaesthetised exams with radiography, whereas awake visual exams can miss quite about between 20 and 30% periodontitis. So this really helps identify those ones that look clean but actually do have some severe disease there. So helps you get chatting with the client, and with the Pluctive range and the fact that it does you can use it in those puppies and kittens right from the start and ensure that they have good oral health throughout their lifetime. So. And that's pretty much it from us. We've just started a YouTube channel, so we've got a bunch of videos on there. So this is our third in a series of roadshows. So we've had Dr. Desbier speaking on I can't remember exactly the topic, but it was basically pre-clinic treatments. So having happy pets coming in to see happy vets. And so that's up on the YouTube channel. Last week we were in Christchurch, and Dr. Janine Van Dam talked on periodontal disease and 5 common referral cases. So that's also just been put up online, and we'll get that in this presentation go up in the next few months as well. So, and there's a bunch of other stuff on there as well. So yeah, and certainly watch this space. We've got a whole bunch of products coming. You know, our aim at GLA Pharma is to bring unique and novel products to you guys to help with your care of your animals and hopefully improve animal welfare outcomes long term. So yeah, we certainly, being a vet myself, I try and cherry pick the best things that come across my desk. So they are things that will work and should make sense. So. Cool, righto, thank you.
Thank you.